So this is a program that I found online from Lake EMS from 2012. And I thought it was very informative. So I took a look over it and I thought it would fit perfectly well for what we're doing up here in capnography. So I kind of stole his program and using it professionally. And I'm giving him credit because his name's still on here. So Scott Temple from Lake EMS developed this program, thought it was pretty good. And we'll go through it. So we're going to kind of brush through this pretty quickly as we just went over all this in the previous presentation in regards to oxygenation versus ventilation. But we'll just touch on it really quick. Oxygenation is the ability of the red blood cells to pick up the oxygen and move them through the tissues of the body, right? That's how we oxygenate the system. Ventilation is the exchange of air between the lungs and the environment, including inhalation and exhalation. So we have to have good ventilation to provide good oxygenation. And to do so, we have to either help support it or the patient can do it on their own. And we have to make the determination of when we need to start providing, I keep using the word crutch, that crutch to assist with that process. And we have to make that determination based on our initial assessment. By walking through the door and being like, this patient is sick or are they not sick? By looking at, skin color and temp, how they're speaking with us, whether it's looking at word dyspnea, getting vital signs. What do we need to utilize? Do we need to help with that oxygenation and maybe assist with ventilation or help support the ventilatory process? We really hit cellular metabolism as well and how blood is circulated through the body. So I'll just do a quick recap. Air comes in, goes into the alveoli. Oxygen comes in, picked up by the red blood cells. Red blood cells then circulate through the body via the left atria to left ventricle into the system. Comes back around from the arteries to the arterioles to the capillary bed, where then it is then dispersed out and the bad stuff comes in, carbon dioxide, then transported back to the heart through the venules, to the veins, in through the right atrium, in through the right ventricle, into the lungs, to the alveoli, where then we exhale, and the bad stuff, carbon dioxide, comes out, and then as we inhale again, more good stuff, oxygen comes back in. That is our cellular metabolism. So, pulse oximetry and capnography. So pulse oximetry measures oxygenation and can be provided in a waveform. Capnography also measures ventilation and can also be provided in a graphical waveform for interpretation. So looking at this, okay, down below here, the very bottom line, that is our waveform capnography for end-tidal CO2, okay, which is represented by a number here. This is 35. Our normal range is between 35 and 45. That's our normal range for end-tidal. Anything above 45 we consider acidotic. Anything below that would be considered alkalotic. And then we have our waveform for SpO2. So we want it to look similar to this. Okay, and this should coincide with the heartbeats. So this should be going right now 80 times a minute. This is called pleth. We want to make sure we have good pleth to make sure that we're actually getting an accurate reading. Again, these are tools of the trade, but don't let that be your end-all, be-all determination of how we're going to treat our patients. So oxygen is measured with pulse oximetry, SpO2, which is a non-invasive measurement, expresses all the percentage of the oxygen in red blood cells. Now remember I mentioned before, if carbon monoxide is in the system, it's still going to pick it up and thinking that it's oxygen. So all it's measuring is what is attached to that red blood cell. Right? Changes in oxygenation can take minutes to be detected, up to 5 minutes at a time, for when you notice there's a change in oxygenation. And this can be affected by motion artifact, poor perfusion, nail polish, and some dysrhythmias. These are some pulse oximetry waveforms. So as you can see here, this is a normal waveform on the top line. With an irregular heart rate, you'll see something like this. It'd be beat, 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 that pause in between. The same thing over here, irregular heartbeats. If you see something that almost looks like VFib or very, very fine lines, this could be a weak signal, okay? Again, nail polish, cold fingers, hypothermic patients, things like that, you may not get that adequate waveform that we're looking for, right? This is why pulse oximetry is not the end-all be-all tool that we should be utilizing to see if our patient's perfusing appropriately. Ventilation now is measured by end-tidal CO2, which is partial pressure, milliliters of mercury, or volume, percentage of volume, of CO2 in the airway at the end of an exhalation. So a breath-to-breath measurement provides information within seconds, not affected by motion artifact, poor perfusion, or dysrhythmias. This is real-time look at what's actually going on with the patient. As we can see in pictures A, B, and C, okay, looking at A being a normal waveform and C being potential for apnea. Oxygenation is for metabolism. That's what oxygen is for. Versus carbon dioxide, this is from metabolism. Oxygenation is measured by SpO2, which is a percentage of oxygen in red blood cells. Under ventilation, end-tidal measures the exhaled carbon dioxide at the point of exits. Oxygenation reflects change in oxygenation within 5 minutes. Reflects change within ventilation within 10 seconds. Okay, so we can see that change quickly, minutes before you'll see an SpO2 decrease. The patient becomes apneic. So don't believe me about the time. If you have a cardiac monitor, try it out. Turn on the monitor and put on the end-tidal CO2 filter on the line, and then an SpO2 sensor. Now hold your breath. You will see that the capnography will show apnea almost immediately. And SpO2 will continue to show a high saturation because it does not register for several minutes. All right. So you could have a patient, if you're not paying attention to your patient, let's say a BLS discharge, okay, and you're monitoring pulse oximetry and vitals every 15 minutes, no cardiac monitor. The patient could stop breathing on you for like 3 minutes, become apneic before you start seeing a major decrease in pulse oximetry. At that point in time now, the patient has had no oxygen coming in for 3 minutes. How long does it take for brain tissue to start dying? And heart tissue? What are your thoughts?
Mine started dying when I was born.
Yep.
I think it takes about 30 seconds, doesn't it?
They can start
it begins.
Yeah, when it begins, and then what they say is there's about 6 minutes you can have with no oxygenation. Like CPR. You start losing, remember how he's always talking about time is muscle, right? A patient having a STEMI without getting proper treatments, time is muscle, right? We need that oxygen getting through the center of the heart, right? If we're not perfusing, things start to die. That's why it's so important for us to get high flow oxygen on patients that are having STEMIs to help oxygenate the system, right? But also in turn, we also make sure we're oxygenating the patients that are not breathing effectively, because eventually something's got to give, right? That's why it's so important to oxygenate. And if you waited, and then this happens a lot, I've seen this on BLS discharges, where they sit in the airway seat and they don't monitor their patient other than SpO2 and vitals or blood pressure. Now, if you set it for every 15 minutes, 15 minutes later, the patient has a blood pressure of 60 over 40 because everything's decompensating because they've gone 15 minutes without breathing. So you want to make sure you're paying attention to your patients. End-tidal would have picked that up in 10 seconds. And then now, believe me, I'm not saying every BLS discharge put end-tidal CO2 on through nasal cannula. That's not what I'm saying. That would cost companies a fortune. Patients that require it should be on it, though. So pre-hospital use of capnography. Immediate information via breath-to-breath monitoring. Immediately, we can see this. It's information on airway, breathing, and circulation. It also helps with documentation purposes as well. And we'll get into that. Airway, it's a verification of ET tube placement. It's also a verification of King Airways, combi tubes. My God, I'm dating myself a little bit. King Airways, LMAs, iGels, any kind of supraglottic airway. It works with supraglottic and paraglottic, either one. Okay, it helps that tube verification. Also, continuous monitoring of ET tube positioning. So if you have a vented patient, you're taking on a transfer, they need to be on end tidal, right? And just for future reference, if you have the Zoll monitors, Memorial's end tidal is compatible with ours, with our monitors for Zolls. Uses of capnography for breathing would be hyper and hypoventilation. So you can see the changes in the rhythms, the waveform, along with asthmatics, and you can also see COPD on it as well, which we'll cover here in a little bit. And then for circulation, checking the effectiveness of compressions during cardiac arrest. It monitors low perfusion states and is also a first indicator of ROSC. So if you have a patient who is let's say a systole or a VFib, okay, or PEA, and you see an end tidal spike to like 50, 90% of the time, if not higher, they're going to get a pulse within 2 minutes. So check for a pulse. It also shows good effective CPR. So if you have a Lucas device and you have someone on end tidal, that device does such good compressions, it'll actually develop a blood pressure on patients and show good perfusion status with end tidal as well. Other things to kind of pay attention to as well. If a patient has like overdosed on antacids and you intubate them and it goes in their esophagus and you miss the tube, you may get end tidal readings as well from that antacid stuff off gassing. That's one of those rare things, but just keep that kind of stuff in mind too. The best way to make sure you're definitely in is visualization through the cords and good end tidal. Make sure you get that good visualization as well. That's why glide scopes with video scopes, I should say, are hands down one of the best devices ever for managing airways. Documentation purposes is with all the documentation, capnography can be utilized as the legal evidence pertaining to the care of a patient that received during a call. The following are examples of information that capnography provides. One, a baseline capnography assessment. It also gives you waveform appearance and changes in the waveform with treatments. So it's called trending. End tidal CO2 values as well. Okay, all this good information. And when you upload stuff to EasyPCR, right, your end tidal waveform also gets uploaded to the PCR program, along with your numbers. Your waveform and your numbers both get uploaded. Documenting the actual numbers shown on the monitor and how they also change during a transport. There's no faking this. You cannot go in, well, you can go in there and edit the numbers if you really wanted to, but you cannot edit the waveform, right? It's there. So it's a good documentation purpose for documentation. Capnography in intubated patients verifies documents ET tube placement, immediately detects changes in ET tube positioning, assess effectiveness of chest compressions, early indication of ROSC, indicator of probability of successful resuscitation, and allows crews to adjust manual ventilations in accordance with patients' needs. So if we're using the BVM. In the world of interfacility transport, it will help us also determine if we need to increase respiratory rate, increase your I times, do we need to change tidal volume? That a lot of that stuff will help us make determinations on how we're going to treat our patient even during transport, because there are times where ventilator management has to be done. And anytime you have a patient with an ET tube in place, whether it be 911 or interfacility transport, if you're going to move a patient, you want to get lung sounds prior to moving it and make sure you note the number of the teeth or the lips for the tube. When you move them, recheck lung sounds. Check your cuff again, make sure it didn't deflate somehow, right? Because that can change your end tidal as well. We'll also start giving you more vent alarms. That's a whole different class in itself, how to be able to make do with the vent alarms and how to treat them. So research in capnography. In 2005, study compared field intubations that used capnography to confirm tube placement versus intubations that did not use capnography to confirm placement. And the study showed that 0% of the intubations went unrecognized if misplaced when end tidal CO2 monitoring was used. 23% went unrecognized in the non-end-tidal monitored group. That's why we confirm intubations with waveform capnography. This is why. 23% went unrecognized in the non-end-tidal monitored group. That's a lot of missed tubes that we shouldn't be missing. Capnography in non-intubated patients assists in the assessment of acute respiratory disorders like asthma, COPD, among many others, and it helps in determining the patient's response to our treatments, right? So if we have a patient who's an asthmatic or a COPDer, and we start seeing that shark fin waveform, are the treatments that we're giving, from albuterol treatments for bronchodilators, sympathomimetics, to your mag sulfates for your smooth muscle relaxant, to corticosteroids that we're giving, Dex or Solumedrol, are they working? And the only way to really tell if they're working is by looking at your end-tidal changes. Is that shark fin going away? Are we opening up the lungs enough for our alveoli to off-gas at the same time versus in different times of the phase, which is causing that shark fin form? We're going to contribute in the formulation of a field diagnosis for this as well. So if we see shark fin, we know that it's a bronchoconstriction issue. We have to bronchodilate them, right? So that's where this is going to come into play. Other hypoventilating non-intubated patients as well, capnography will estimate the severity of the condition that leads to hypoventilation, whether it be stroke, head injury, ETUH intoxication, drug overdose, DKA patients, congestive heart failure, or analgesia, or sedation medications, right? So in the next month or so, we should have RSI here. With that being said, end-tidal is going to be huge for us to be able to do that. So when we're doing one of the things we could also place on the patient when we're doing nitrogen washout is we could put a nasal cannula with end-tidal on, and then also do your non-rebreather as we're doing nitrogen washout with the patient before we intubate. With that being said, this would be very helpful in a delayed sequence induction where we're giving ketamine prior to maybe intubate, 3 to 5 minutes after, versus doing etomidate and suck, which is a more rapid sequence induction versus your delayed, where we start looking at ketamine and rock. So with that being said, utilize the tools that we have for what we're doing. Now, if the patient is being intubated anyways, they probably should already be on end-tidal, at least nasal cannula either way. So it's already going to be there. End-tidal CO2 reflects changes in ventilation, movement of the air in and out of the lungs, diffusion exchange of the gas between the air-filled alveoli and the pulmonary circulation, and it also measures perfusion, which is circulation of the blood. You'll start seeing changes in end-tidal based on these. So what's occurring in the lungs? We have the right ventricle pumping in deoxygenated blood into the arteries. As it's circulating through diffusion, carbon dioxide is pushed into the alveoli, and through diffusion, oxygen is going back into the circulatory system, right, through the vein into the left atrium, where the left atrium then pumps it through the valve into the left ventricle, which then pumps it out to the the body. That's going to be our pulmonary blood flow, in which I already covered here. All right. Where deoxygenated blood and oxygenated blood come together, that's perfusion. That's where the perfusion is actually happening. Okay? And that's being pushed out to go to the capillary beds where more perfusion is at, where we're perfusing the cells. Again, I hit this enough earlier in this slide along with the one we did previously, so I'm not going to keep going over it in depth. You can see it's picked up, oxygenated, going into left atrium, left ventricle, into the body. And with ventilation, exhalation, the carbon dioxide is exhaled, and we now capture it via the capnography filter line. So a little bit about filter line maintenance before we get into the changes and levels. If we have a patient who is either on, if you're utilizing it through your BiPAP and you put it in line between them to measure the off gas, if you have a patient that's intubated, whatever it may be, okay? Make sure that when you place your end tidal filter line in place, your mainstream filter line, that the filter line coming off is aiming towards the sky. Right? As patients are intubated, or if they're exhaling and also giving off moisture, right? If that's the case, water or moisture can actually get into your filter line. That's pulling this stuff through a vacuum and can clog your line and give you false readings. So you want that moisture to build up on the bottom of the tube or bottom of the filter line device versus the top part where it can actually suck it in. So make sure everything's aiming north. Right, that'll help you tremendously when you're looking at intubated patients. Kind of a little trick of the trade when you're doing that. Changes in end tidal levels. So why end tidal CO2 levels decrease? They decrease in cardiac output. So cardiac arrest, as you can see, the changes, let's say this is at 45 and it's going down. Or pulmonary embolus will also cause a decrease in end tidal, bronchospasm, decreased muscular activity, and hypothermia. These are events where you'll see a decreased level of end tidal. You'll see increased end tidal levels during good compressions and a cardiac arrest, the increased muscular activity, like shivering, or effective therapy for bronchospasms, right? So that's our bronchodilation, whether we use, like I said before, we use ipratropium bromide, albuterol, Duoneb, our MAGs, EPIs, the corticosteroids, even oxygenation with CPAP can help with this as well. So all these different medications and therapies we're using for bronchospasm will see that increased level of end tidal. So the anatomy of a waveform, the height shows the amount of carbon dioxide exhaled. So as we're exhaling, we're coming up and then it plateaus off, and our end tidal reading is going to be at the peak before we start seeing the inhalation again, so the very end part. The length shows the time. This represents one respiratory cycle. So inhalation, exhalation. So again, exhale, inhale, exhale, inhalation, back down again, and then the next waveform will start. So this is kind of a breakdown. So phase one is the baseline of the formation, where the initial upstroke going in for the exhalation starts. Represents the exhaled gas from the upper airways, aka the anatomical dead space. So many reverse this and believe that it begins inhalation, and it does not. Okay, so inhalation, exhalation starts as the upstroke goes into phase two. Those are getting the many dead space ventilation begins in exhalation. CO2 is absent. Air is coming from the mouth, nose, and pharynx, and gas exchange does not occur at this point. Okay. So dead space is a ventilated area that does not take part in exchanging of gas. So if I go back a slide, this is going to be your dead space up here. Right? So that does not take part in any gas exchange. These are the airways leading into the alveoli and ventilated areas in the lungs without blood flow. Phase two is the ascending phase, right? So we start seeing that upstroke going up into the plateau. So the CO2 from the alveoli reaches the upper airway and mixes with the dead space air. So this is why you see a rise in end tidal CO2. CO2 is now detectable and exhaled via air capnography. And it's air via capnography, right? So that was phase two here. Phase three is CO2 exhalation, where the wave plateaus off. It kind of stays on a plateau. This shows alveolar gas exchange, which indicates changes in gas distribution, and increasing in the slope indicates problems with distribution of gas delivery. So the alveolar plateau, CO2, now makes up the majority of exhaled air. The concentration of the CO2 remains fairly constant from the alveoli to the nose and mouth at this phase. Right? So phase three end tidal, which you can see here, that's where we get our readings from, right, is the end of exhalation that contains the highest concentration of carbon dioxide, the end titled CO2. So the star here marks the end of the wave. And then the patient inhales and it goes back down again. So phase 4, the descending phase, is the beginning of inhalation. Where CO2 levels drop to baseline 0, and oxygen is now in the airways. So what is the normal range for capnography waveform? I mentioned it earlier. What is our normal range?
35 to 45. 35 to 45.
Thanks, Dave. Yes. So 35 to 45. Perfect. So abnormal values. That's what we got to pay attention to. We all know the normal value. Let's talk about abnormal. So end-tidal CO2 less than 35 would indicate hyperventilation or hypocapnia. Hypocapnia would be low CO levels. Okay. Hyperventilating. You're going to see that it's low. End-tidal CO2 greater than 45 would be your hypoventilation or your hypercapnia, right? High levels of carbon dioxide. So would this patient here be acidotic?
Yes, but we get this long term here. Does the number change so we can get someone who is hypoventilating with a shorter ventilation period, or does it always have to be long?
So when they're hypoventilating, all right, normally it'll be normally it's a longer phase because they're breathing so slow versus your rapid hyperventilation when you have your shorter period. Is that what you're looking for, Dave?
Yeah, the period, I'm surprised the period is that long for the hypoventilation. But the number, that shows the indication is that they have a very high number, greater than 45. We have someone who has been down for a while and we're ventilating. We start off maybe at 58, maybe for a end tidal, and then until we start bagging them and get our gases back to normal. So the numbers will slowly come back down with that. But will we still have that long one because we're bagging the person, or will it'll be shorter?
Well,
but high numbers.
If you're bagging the person, we're hoping that you're fixing hypoventilation and getting them to a rate between 12 and 20 a minute. That's kind of our goal, right? So you should see the numbers when you're ventilating now, BVM, start to decrease and get back into normal range, and you won't see that long pause the long exhalation phase.
Right. All right. Phase 2 would not be as long. All right.
Correct. So how would your waveform change if you are intentionally started to breathe at a rate of 40 times a minute? How would your waveform change if you're breathing at 40 times a minute? Let's go with an adult, not a pediatric.
You looked at the duration will be shorter, the height will be lower, and the frequency of the wave will be shortened.
Perfect. As you can see here, hyperventilation. So we're going to see that decreased end tidal and then shorter space of phase 2. You notice the pink waves are under the 45 line. So maybe you're right around 35, so still maybe normal, but they're still ventilating faster, hyperventilation. But the faster they go for the longer period, eventually the stuff's going to start dropping down. All right. So interventions for this, as far as hyperventilation, adjust the ventilation rate. So that's all we have to do. Decrease pulmonary perfusion. Evaluate for adequate sedation. Is the patient sedated enough? Right? Do we need to give more fentanyl, more Versed, depending on blood pressure? So we need to increase our propofol during our transport. If we got fentanyl and Versed drips running, the normal that is usually 100 of fentanyl an hour and 5 of Versed an hour. Do we need to increase those during our transport? Or do we want to go with push dose instead of just doing IV drip as a supplement to keep them down? Or do we switch over to ketamine? That'll be a discussion with your physicians prior to doing your transport. And if it's a 911 phase, all right, if they're intubated, we got to increase sedation. But if they're not intubated and they're just breathing, hyperventilating, we can use a BVM to help control that.
Hey, Kevin, on that last patient we took on Thursday,
Yeah.
Would you have wanted to switch over from the propofol to the ketamine on her?
I think ketamine would have been a better option for her. And we probably could have gotten rid of the Versed and fentanyl and dropped down from 8 drips to like 5.
Right.
But the doctor didn't want to switch out of propofol. One of the things I've noticed, Dave, is that hospitals love using propofol Diprovan for these patients. I don't know why they switched to that so quickly, especially patients that are on norepinephrine. Why would you want to give something that drops blood pressure and give something that increases blood pressure? Why not go with fentanyl Versed?
I have seen that numerous times. That's always been the problem with our patients that you got them on propofol and they're maxing on out because we're looking at their blood pressure and we're concerned about their blood pressure dropping, and yet we're using the wrong medication.
Right.
I don't know why they're doing that, and they have the MD and I have the DK.
And there's nothing wrong with ketamine use, but a lot of places don't use ketamine. Even if you give ketamine for combative patient, they don't like it, or pain management. And ketamine and fentanyl together is a phenomenal combination for pain management.
Yeah.
But a lot of people don't like, a lot of facilities don't like ketamine coming in.
And less side effects.
Well, yeah, absolutely. And
Right.
and if you give it intramuscular, you can give 50 milligrams max dose or first dose.
All right. Well, we'll start asking for ketamine drips instead of propofol in the future.
You can, but
the doctor does.
The doctor may want you to keep propofol running. And if that's the case, then you got to find a way to help increase sedation during transport, and that may be your Versed and fentanyl pushes.
Yeah.
You just got to play it. Make sure they're sedated enough. Other options is administering more rocuronium for the transport as your paralytic.
Right.
So again, we'll have all those medications on our trucks to utilize either way, eventually.
All right.
Hypothermia, evaluate anxiety. If they're hypothermic and they're anxious, let's give them something to make them less anxious. Ativan, Versed. Decrease metabolism, conserve body heat, warm them up. High heat loss areas, head, side of the neck, armpits, and groin. Put heat packs in those areas and warm them up.
Or use the heat blankets that we have.
Exactly. We carry 2 per truck.
Are we actually using the rectal thermometers only for pediatrics, or are we going to use those for adults? Or are we accepting the scanner for the head? What's the deal?
So the rectal thermometers are initially purchased to confirm dead bodies, but
I didn't think so. No, because I thought they was more because the oral thermometers did not go down below 96. We needed something that went below 96.
Yes. So that's another reason why we have them, but they initially got purchased because of the DOAs. I'm not going to get into it over a recorded lecture of why they end up on the truck so fast. But we can be utilizing these for our patients adult, pediatric, doesn't really matter because we need to get a good core temp. These Zoll monitors for services that have Zolls, you have the ability to get different monitoring probes for these. They have esophageal, rectal, and then skin probe temperature monitoring that you can do for continuous temp monitoring. Again, something that they cost money, but if you're doing a long distance transfer, especially if an intubated patient, maybe having the ability to do esophageal temperature monitoring may not be a bad idea for hypothermic patients. You know, if all you have are the skin probe ones, the best place to place those is in the armpit, and you tape them in there. Don't put them on the temples and everything else. It's not going to get an accurate reading. Stick them in the armpits, tape them up, metal side to the skin, right up in the armpit, put the arm down, and you're going to get accurate readings with your monitoring.
Kevin, do you know what temperature those IV warmers warm the fluid to?
Wow. Dave, what is it, like 105? The hospitals are 104, 105 degrees.
I think ours are more like about 102. I'll go take a check on one.
All right, so I know it's over 100. I know that. It's supposed to be anyways. The only problem with ours, Joe, is that the red bags that we have, they're all brand new.
They don't always,
Well, they're all brand
work
new.
either.
The problem with them is that the plug in the back of it, it's so easy to pull out. They're not like hardwired in. So you've got to check those on your ship, because any bumps in the truck cause them to fall out. I'm tempted to put some tape around them and tape them in. You know, they kind of make that work. All right. So how would your waveform change if you intentionally decrease your respiratory rate to 10? What would you see in a change in that?
See a longer waveform, less frequency.
And then height would be higher or lower?
Height would be lower.
Correct. As you can see here, we'll see our higher numbers, and there'll be longer duration, right? Perfect.
Oh yeah, I was wrong. Height would be higher because of the higher end
Yes.
tidal.
Yep. So hyperventilation, higher end tidal, longer duration, and then they'll be slow. So this indicates hypoventilation. So again, adjust your ventilation rate. Respiratory depressant drugs, decrease respiratory depressant drug dosaging if you have them.
Kevin?
Yes, Dave.
Sorry to interrupt you. I went out, I did thermit. The bag, the yellow or the orange or red bag, the new ones warm our fluids to 104.7.
There you go. Hospitals just keep theirs at like 104 to 105. So yeah. And every patient, especially during this time of year, should be getting warm fluids. Unless they're hyperthermic, even normal thermic patients should get warm fluids every time. You shouldn't be pulling them out of the cabinets. They should be coming right out of the IV warmer into the patient and then put the new one on the warmer. That's something that we don't do enough of.
Trauma patients especially.
Yeah.
Even in the summertime, studies showed in Iraq that like 86% of trauma patients with blood loss were coming in hypothermic, even in Iraq when the temperature outside was over 100.
I have dispatch calling me, so hang tight 1 second. Hey, Dave.
Yes.
You guys have a BLS going to Concord at 1.
At 1 o'clock, a BLS to Concord.
Yep.
Okay.
I may try to make some different arrangements, but we'll see what happens. I got to work on that. All right, continuing on. And increase metabolism, maintain normal body temperature. All right, don't let them become hyperthermic or hypothermic. Just keep normal body temp with that. So as you can see here in the pictures, normal waveform, hyperventilation, hypoventilation. So increase short, decreased. That's right, increase long, decrease short, normal, 45. All right, perfect. So what's happening here?
Yeah, there are multiple areas of the alveoli that are off gassing or being exchanged this time. So we don't have a smooth phase 2 there. It's lumped a little bit. So we're not getting a good, for some reason, not getting a good release of gas all at once.
Right. So where would you see this patient? What kind of patient would you see this in?
COPD, someone who has crackles in their lungs.
So bronchoconstriction, bronchospasm.
Bronchospasm would be another one, yes.
Okay, perfect. This is called the shark fin, right? Here we go. Here is the shark fin. So bronchospasm restricts proper ventilation with the alveoli unevenly filled during inspiration, and they also empty unevenly during expiration. This is where you get that shark fin look. Uneven airflow during exhalation dilutes exhaled carbon dioxide. And this alters the ascending phase of the plateau, slower rise in CO2 concentration. Characteristic patterns for bronchospasm would be the shark fin waveform. So that's what we're seeing here. So we're seeing that off-gassing coming from different parts of the off-gassing differently from the alveoli. Instead of all at once, it goes in like a wave. So now we've learned bronchoconstriction. That's a fourth waveform that we've learned now. All right, so capnography in advanced airways, inline. So this is some more stuff we need to pay attention to as well. Confirmation of the tube. So utilize to confirm that your tube is in place. Remember that improper placement of the tube will result in a lack of waveform. This tube is confirmed, right? We're starting to see the waveform here as they're ventilating, even if they're not conscious, not breathing, right? You're starting to see our waveform go up and up with normal plateaus. This means that we are in, okay? This is confirmed placement.
Kevin?
Yes, Dave.
That waveform is recorded on the monitor. Is that a continuous one, or does it only come up and noted when we have our vital signs taken every 5 or 10 or 15 minutes?
So it's supposed to be continuous. So if you go to the Zoll Cloud actually takes in a lot of info. It's what your service has programmed to upload to your report.
Okay.
Yeah. So that's why we have to push snapshot for our EKGs, because those are the ones that it will upload.
Right. Right. You push it for the 4 leads. If you do a 12 lead, it automatically does it, but
That
not before.
Correct. Yes. Because every little bump you hit in the road, and I call it Z-fib for Zolfib, it will recognize that, and then that would upload to your report, and your report would be like 80 pages long. So it only picks up the ones that you push. Or anytime you do a shock, it does it as well. But if you get on scene to confirm a death, a DOA, right? Or if you're, let's see, you worked in 20 minutes in a systole with no shocks, you've got to push the snapshot button on our monitors, or it's not going to save any of it. Right? So that's one thing you remember to do. So medical legal, capnography provides documentation of correct placement, ongoing documentation over the time through the trending printout, and documentation of correct position at the ED arrival. If physicians see this, there's no reason for them to pull the tube out and put them in themselves, right? This shows accurate readings that you're in. Now, if you have good readings, next thing you know, you see it looks like V-tip down here at the bottom. That means that your tube has been displaced somehow, right? So tube dislodgement is immediately detected when waveform suddenly drops. Initially, this tube was confirmed, then displaced, right? That's why it's so important to hold, secure it in place, make sure your cuff is filled, check your pressures inside your cuff as well. Make sure there's actually pressure in there. We're not losing any kind of air. This will also change a lot in your pressure alarms as well, along with your minute volume alarms. Detect ET tube displacement. This is only provided through the use of capnography. A continuous numerical value of end tidal with apnea alarm for 30 seconds. If you have the alarm set. And a continuous graphic waveform for immediate visual recognition as well. As you can see here, the tube somehow got dislodged, and now there's no more waveform. So can capnography assist with CPR? Absolutely it can. Determination of how effective your chest compressions are. It helps to show early detection and ROSC. It provides data for the decision to cease resuscitation. Like the end tidal CO2 reading remains under 10 for over 20 minutes of working at code. Right? If it's under 10, the chances of coming back are very, 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 very slim. Versus when you start CPR and you put on even the end tidal through a BVM, and you're starting to see readings of 30, 25, 20, you have a higher chance of getting ROSC versus someone who has less than 10. So kind of keep that kind of stuff in mind as well. When a patient is in cardiac arrest, remember the end tidal CO2 is going to be low. The patient is not perfusing enough, therefore gas exchange is not occurring appropriately. In a cardiac arrest, we are hoping to keep the end tidal around 10 to 15. Without a number this high, the chances of getting ROSC are very low. So you can increase the end tidal CO2 by providing better compressions, all right, thus providing better perfusion to the alveoli during CPR. So how does providing better compressions help rise end tidal CO2 numbers? So how would you think that would help?
You increase your chest compressions, make sure that you are relieving all the pressure off, so you get a negative and a full negative pressure grade in the chest wall, and then you want to watch out for the ventilations, make sure that they're not hyper ventilating with too much oxygen, too long of a period of positive. So watching the respirations versus compression ratio to maximize that properly can give us better results.
Exactly. Yep. And it's all about perfusion. Everything that Dave just said in the one word, perfusion. We have to perfuse the body, and that's what good CPR does. And it's been proven that mechanical CPR is way better than doing CPR by person. So again, if you have the ability to have a Lucas, those things can do a phenomenal job with perfusing the body. So let's go back to 1978. Some of us, we were not born yet. For some people, you guys were alive. So a scientist reported a decrease in end tidal CO2 as the person performing CPR fatigued, followed by an increase in end tidal CO2 as a new rescuer took over. Imagine that. 1978, they found this.
It's funny he's reporting it in 2004, though.
Yep.
You know when they started using the compression automatic compression device, Lucas?
Yeah, I'm not sure when they started those.
If you watch the very first episode of Emergency, you'll see them using the air tank powered one off the SCBA tank.
Interesting.
Yeah, that was like 1974 or something.
Yeah, no, that was actually Squad 51 was back in the late in the 70s, early 70s.
Right.
Maybe 60s, who knows?
All right. Can you guys still see my screen okay?
Well, we can see the 1978 one.
Yep, that's what I'm on. I just put it up on the big screen because A3 just came back. so they can jump in and partake in the training. A little too fast there. Another study suggests that reductions in end tidal during CPR are associated with comparable reductions in cardiac output. To the extent which resuscitation maneuvers, especially precordial compressions, maintain cardiac output may be more readily assessed by measurements of end tidal than palpation of arterial pulses. Yeah, it's old, but it still applies today. So it's still there.
Where's the other chair?
Out back in the right.
Huh?
Out back by the right. By 6.
All right, so new guidelines with the American Heart Association guidelines for quality compressions: push hard, push fast, push deep. Rescuers will switch places every 2 minutes, right? And it's still being pushed today. Now, this presentation was made in 2012, but even in 2021, it's still being pushed that direction. So we encourage you to keep an eye on end tidal numbers as high as possible during CPR. That's our goal behind it. So what is this a sign of if you see this?
Call paramedic.
Ross.
Yeah, exactly. If it would open. There we go. So retention of carbon dioxide. So obviously if we get Ross, we're going to see this number bounce as high as we can, the 50s, 60s, because we retain so much CO2 or carbon dioxide while being in cardiac arrest. Then when we get pulses back, and all of a sudden it perfuses, it pushes us forward. The wave is large because the patient in cardiac arrest has been retaining carbon dioxide. So when ROSC is achieved, the patient whose heart is now working is able to perfuse better, getting rid of the retained carbon dioxide that's there. The exhalation of then retained carbon dioxide that gives off the box such a high appearance. So ROSC and end tidal. Survived the discharge from hospital, average end tidal 30. Non-survivors had an average end tidal of between 4 to 10. Increasing the cranial pressure and ICP and capnography. So ICP and end tidal CO2 levels. Capnography should also be utilized in patients with ICP issues, so head traumas. The following ICP patients are very sensitive to fluctuations in end tidal levels: stroke patients with possible bleeds, trauma to the head, brain tumors, neoplasms, or brain infections. So what are the 3 things we look for, and what is it called to recognize ICP?
The triad.
Yeah, the triad. So we'll talk about
Cushing.
Cushing's. Okay. And what are the 3 things we look for?
Increased blood pressure, decreased respirations, and bradycardia.
Yes. And not only just the decreased respirations, but you'll have a regular respiratory pattern. That's correct. So that's your Cushing's triad. All right. So what do you think will occur to cerebral vasculature if the patient has high end tidals, high levels of carbon dioxide?
Brain dead.
Okay.
They dilate.
Yeah. So sum it up. Brain dead, right? Yeah. Is not working. There we go. All right. So cerebral vasoconstriction with low carbon dioxide levels lead to cerebral vasoconstriction. The good. It lowers carbon dioxide levels that can cause mild cerebral vasoconstriction, which may decrease ICP. However, the bad part of it is Although low CO2 levels decrease ICP, it may cause or increase cerebral hypoxia, right? And we don't want cerebral hypoxia. So some of the pearls behind this, hypoventilation increases CO2 levels, not blowing off enough CO2 results in cerebral vasodilation. But if hyperventilation decreases the levels, blowing off too much CO2 results in vasoconstriction, right? So how do we treat ICP patients now? Just ventilate them normal.
Just ventilate normally to try to get in your SpO2 levels. So
Right.
give them oxygen and try to up the percentage of SpO2.
Yeah, so like Dave just said, utilize capnography in conjunction with pulse oximetry. Your target should be an end tidal of 35. So just ventilate normal and run off end tidal. If it maintains 35, then you're perfusing where you need to perfuse. Right? We don't have to worry about it becoming hypoxic. Right? So we'll be able to avoid cerebral hypoxia, maintaining adequate cerebral blood flow.
You guys can
Is normal ventilation. We do not. So Paul is here right now too. They just came back from a call. He is asking if we can give mannitol in the field. So we don't have mannitol available. And I haven't seen that much given in ERs either for patients like that now. But it's still out there though. I want to say it was 100 milligrams of mannitol.
Yeah.
No, we just use a Makita drill and just drill some boreholes.
I'm down.
All right. So warning when hyperventilating patients. Excuse me. Recent evidence suggests hyperventilation leads to ischemia almost immediately. Current models of both ischemic and traumatic brain injury suggest an immediate period during which the brain is especially vulnerable to secondary insults. This underscores the importance of avoiding hyperventilation in the pre-hospital environment. Okay, just don't do it. Just give them normal ventilation to maintain end tidal at 35 and a good pulse oximetry, or greater than 94. Other patients that need CO2 monitoring are going to be your COPDers, emphysema, bronchitis, asthmatics, CHF, pulmonary edema, pneumonia, a possible for PE, and cardiac ischemia. So I've done this class before, and I know that Scott sat through this before as well. And I'm glad he's sitting through it again because it's a good refresher. He mentioned to me after the fact, he goes, so we're basically putting an end tidal on everybody. And he's not wrong. Most of the patients we have should have a minimum of nasal capnography for the patients that we're seeing that are sick, right? It also includes septic patients, right? So sepsis patients should also have it on as well. So why should you use capnography for these patients? To assess and trend your patients. That's why we're using it. To look for low perfusion status, hypoventilation statuses, to identify changes in capnography waveform, like bronchospasm and COPD and asthmatic patients. So that way we can see that trend and see where things are going in these patients as well based on our treatments. And are our treatments actually working? Right? And that's what we're looking for. So as we mentioned before, capnography and bronchospasm produces changes in ascending phase 2, with the loss of the sharp upslope. We don't have that anymore. So it alters alveolar plateau, producing the shark fin. Because remember how Dave mentioned earlier in the presentation, as well as what I was mentioning as well, is that the patient's alveoli, when they're off-gassing, are not off-gassing all at the same time. It's kind of going into a wave, which then causes that shark fin waveform. As you can see here, normal versus asthma. So what should you see after treatment? After therapy, you should start seeing a more normal waveform after therapy has been given. That allows the bronchioles to dilate and allowing for better gas exchange and off-gassing at the alveolar level. If we're not seeing these treatments, then we have these changes with our treatment, then we have to do more treatments to help with that. So that whether or not going into MAG or going into epi to help open up these airways. So the role of capnography with COPD are patients that have a PaCO2 or partial pressure of carbon dioxide in the arterial gas blood increases. This is the waveform that you will probably see. Right, so normal, or we'll see the abnormal patient presentation here, which will start seeing a higher level of end tidal and a sharp fin look. Notice how the ascending phase and the plateau look abnormal. This is because of the uneven emptying of gases. So we'll have that higher number. So here's a scenario for you here. A 70-year-old female, she complained of dyspnea with a moderate chest pain, history of an MI, a cabbage ×3 on oxygen at 2 liters a minute. Has a heart rate of 60, BP of 144/70, and a rate of 38, labored and shallow. Skin is cool and diaphoretic with some pedal edema. SpO2 is at 79%, end tidal at 20. Can you give me what you think would be a diagnosis of this, and what our treatment's going to be?
Well, she's cold,
Yeah.
technipic, and she has fluid buildup in her extremities. So possible congested heart failure here. We want to, she's not getting perfusion. You can see that by her SpO2. So we want to try to increase her oxygen here and try to lower her respiratory rate. And depending upon the temperature, maybe she needs to be warmed up because of her age, or she can be cold very easily.
All right, perfect. So you place the patient on an on-rebreather at 15 liters a minute. Now your oxygen is up to 100%. All right, you administer an inch of nitro paste. I couldn't change that. Obviously, we can go with nitro tablets and or with nitro drips, depending on what level we're at. During transport, you trend her vitals. This is what you see: 99 and total of 35. In order to see documented improvement in your patients, you must trend your patients, right? So that's setting vital signs every 5 minutes, right? You want to see if you can see that trend and record it. All right, this is it. So the VQ mismatch, ventilation perfusion, this is when the amount of ventilation or perfusion is altered. In pulmonary embolus, the patient has a decreased perfusion when compared to ventilation. This increases our dead space. Remember that dead space is the parts of the airway that are unable to take part in gas exchange due to the lack of perfusion, which we will see here. PE patients therefore show a reduction in exhaled CO2 on your capnography due to increased dead space. The green line represents normal. You notice the end tidal is around 25. Low E is still the low end tidal due to increased dead space that's there, and that this is how a PE patient is way under it, normal levels. Right. So you got a patient with a potential for a PE. So they're anxious, they're short of breath, they had simple episodes. You put them on nasal capnography and you see this. There's a high chance that there is a PE. Okay. So kind of keep that kind of stuff in mind. They're tachycardic. So why use capnography in pulmonary embolus? We should utilize capnography in these patients because it can assist us in forming a field diagnosis. Most of us know what to look for in these patients, so give some examples, which I already did, of how PE patients present. So the anxious, syncope, chest pain, and all that stuff there. All right. So 25-year-old female, shortness of breath and sharp chest pain. No health history. She's on Chantix and Yasmin birth control. Does it sound like a PE candidate? Everybody should be shaking their head up and down. It's a yes. So the patient begins to hyperventilate. You place her on capnography and see this.
24.
Without warning, you see a marked decrease of end tidal and the patient's mental status starts to change to 18. All right, you see hyperventilation, and then it changes over to low end tidal right away. All right, that marked change is your pulmonary embolus. So typically, hyperventilation alone does not cause a sudden rapid drop in end tidal. Your pulmonary embolisms actually do. All right, so remember that a PE will increase the dead space of the lung. So the increased dead space will produce a decrease in exhaled carbon dioxide. Now put the PE signs and symptoms together with end tidal CO2 information, you've just made an excellent field diagnosis. Having the tools are nice, but knowing when to use them is key. We have plenty of tools in our toolbox. We just got to know when we need to start using them on what patients. So if you got a patient that you're transporting for a pulmonary embolus, all right, from an interfacility transport, put them on nasal capnography and monitor that throughout the transport. All right, to know if things are going to be changing. Remember, within 10 seconds, you can have accurate information with end tidal. All right, so how to use it for hypoventilatory states? First, think of some differential diagnoses that can cause a patient to breathe slow. Overdosing, narcotics, things like that. So which of these patients is hypoventilating? A, B, or C? What do you guys think?
I think C.
C, exactly. Right. So we have the long duration with a high end tidal. Patient's acidotic or hypoventilating. All right, perfect. What is this patient doing?
I think someone maybe have disconnected the tube and they reconnected the tubing, so now we have good waveform.
So when the patient lets out a larger exhale, you note that the height increase in one of the boxes. This shows the patient was breathing shallow, but exhaled a high amount of retained carbon dioxide. Okay. So maybe like Kuznets respirations, things like the irregular respiratory pattern. Right. What is occurring here? You're called to a nursing home. As you approach your patient, you know the patient is on O2. An O2 mask and lying semi-fowler. His chin is nearly touching his chest. You place him on capnography, and this is what you see. So what do you see in the picture? What's his baseline?
It's hyperventilating. Probably, the chin is blocking his airway.
So observe this one carefully because something is not right. Right? You know, what is his end tidal on inhalation?
He's staying at about 10.
Right. Note that the baseline is elevated. This is a situation where many patients experience and we don't often recognize. This is called rebreathing. Okay? He is not clearing the dead space that you would allow to return to zero. Right? So the baseline never comes back to zero because of poor positioning of the patient. This also means that he is wearing a mask that allows him to rebreathe his own carbon dioxide. Okay? So you gotta look for those rebreathing. We have to make some adjustments. I get this change here. So what is occurring in DKA?
Were we readjusting the patient, or were we readjusting the staff at the nursing home?
A little bit of both. So diabetic ketoacidosis, DKA. There's an issue with the IDDM and some non-insulin of NIDDM patients is that they do not have insulin available to break down glucose, aka sugar, for energy creation. Instead of IDDM type 1 diabetic, in some cases of NIDDM type 2 diabetics, patients will sometimes have no choice but to utilize fat storage for energy, in the term glucogenesis. So we talk about fat for energy. So fat stores are utilized for energy. Acids called ketones begin to build up in the blood and urine. And the ketones become toxic in high levels. This is what we call ketoacidosis. In many cases, people will find out that they have diabetes because they initially had a DKA experience. These are the patients with a very high blood sugar level and whose breath smells sweet, or sometimes say like an acetone. Right? So we have a buffering system, right? That's our bicarb, in order to balance the acid buildup. But bicarb is a base that opposes acid, decreasing acid levels. Right? So the problem with this is the system is quickly overwhelmed and other mechanisms must work to compensate for the acidosis. So what does the body do? Well, it triggers hyperventilation to lower the blood carbon dioxide levels. So how do DKA patients breathe? Right?
Kussmaul respirations.
Kussmaul's, right? Yes. So ketones are the buildup of causing acidosis, right? We're going to have that Kussmaul respirations. This means that there are high levels of carbon dioxide in the blood. Therefore, you'll see a DKA type waveform. So when patients are in DKA, the body attempts to correct acidosis. By doing so, you're going to have a high level of carbon dioxide in the system, in the body, which creates an acidotic environment. So as you can see here, in the waveform, you are seeing the patient whose body is attempting to correct the acidosis. Note that the end tidal is above 45, showing an acidotic state. And this is why patients breathe fast in DKA initially, because they're trying to blow off that carbon dioxide and therefore lessen the acidosis that may kill them. So again, if you're a patient who's in DKA, throw them on end tidal. However, just like the case of the fast heart rate, a patient's breathing is this fast cannot keep up for long. So what occurs? So the patient then begins a pattern of labored and deep breathing. That's the Kussmaul respirations. All right. So we get into shock patients. So perfusion warning. Capnography can provide an early warning sign of shock. Remember, a patient with a sudden drop in cardiac output will show a drop in end tidal numbers that may be regardless of any change in breathing. This has implications for trauma patients, cardiac patients, and any patient at risk for shock. So another pig study. So 5 pigs had hemorrhagic shock induced by bleeding, 5 pigs had septic shock induced by infusion of E. coli, and 6 pigs had cardiogenic shock induced by repeated episodes of VFib. The pig's cardiac output was continuously measured, as well as their PET CO2. Right. As a result, the patient with low cardiac output caused by cardiogenic shock or hypovolemia resulting from a hemorrhage won't carry as much carbon dioxide per minute back to the lungs to be exhaled. Therefore, the patient's end tidal will be reduced. This does not necessarily mean that the patient is hyperventilating or that the arterial CO2 level is being reduced. Reduced perfusion to the lungs alone causes this phenomenon. The patient's lung function may be perfectly normal. So this is why it's important, even with trauma patients, to put them on oxygen. If you do a nasal cannula, just monitor them with the end tidal. I know that capnography is not cheap, yet it benefits. Yet the benefits for the medic and the patient outweigh the cost. Remember, we can do that at the AEMT level as well. So however, we still want to be selective when utilizing the filter lines that are there. Use it when it's needed. Like I said, not every patient needs to have this. But we want to utilize them for STEMIs, cardiac arrest, respiratory patients on sedation or analgesic meds, altered level of consciousness or mental states like CNS infection, sepsis, drug ETH intoxication, hyperglycemia with DKA, and patients with the potential for increased ICP. Remember that it's just another tool in your arsenal, okay? Utilize it. It's there for you to help, right? this in conjunction with CPAP, and then the next lecture that I'm going to do, which will probably end up being the last one for the day because I have an orientation at 1, will all tie in together. That's why I did this group today. CPAP, we talked about end tidal, now we're going to get into sepsis, right? And I think the 3 of these together will make a huge difference in your treatments. All right. You guys have any questions in regards to capnography? Was that a good review?
Yes, no questions.
Perfect. All right, I gotta figure out how to turn this thing off because I can't see my screen anymore. Oh. No. What does that say? Stop recording.